Yes, yes.
You can start sharing your screen.
Yes. मास्टर व्यू कसं ऑफ करायचं?
क्लासमध्ये
Yeah. So can you see my slide? Slide this. Okay. Good morning, everyone. I will be talking about keratoconus today. So keratoconus, kerato is horn or cornea and conus is cone. It is a non-inflammatory ectatic disorder in which the central or paracentral cornea undergoes progressive thinning and protrusion. Prevalence is 50 to 230 cases per 10,000 people. Asians are more commonly affected, and peak is seen between 15 to 24 years for men and 25 to 34 years among women. Severity and rate of progression is inversely proportional to age. It may, however, commence later in life and progress or arrest at any age. Usually it is bilateral, but unilateral incidence is seen in 2 to 4% of the cases. Pathogenesis can be explained on the basis of mechanical theory, oxidative stress theory, genetic theory, and hormonal basis. Mechanical theory consists of eye rubbing or contact lens wear where there are corneal microtrauma. Oxidative stress theory, in which ultraviolet radiation causes oxidative stress and increased production and or impaired removal of reactive oxygen species. It leads to degradation of the extracellular matrix in the stroma, causing degradation and stromal thinning. Aldehydes cause changes in the membranes of lysosomes, which release proteolytic enzymes. Increased proteolytic enzymes and level of alpha-1 proteinase inhibitor and glucose 6-phosphate dehydrogenase leads to thinning. Genetic theory can be based on various genes, mainly call4 and call4A4 genes, encoding components of type 4 collagen. A major corneal structural protein are involved in keratoconus. Hormonal changes, no direct evidence of a cause and effect relationship, but the condition often first develops at the time of puberty and occasionally during pregnancy or advances during pregnancy. Then there are certain systemic and ocular disorders in association with keratoconus. Down syndrome, there's incidence of 8 to 15%. Leber's congenital amaurosis, disorders of collagen metabolism, VKC, where limbal variety of papillae is more common than palpebral variety. Allergic conjunctivitis, signs of past allergy seen as pseudogerontoxin. Limbal stem cell deficiency, where there is thickening of limbus, conjunctivalization of the cornea. Then joint hypermobility, mitral valve prolapse, HLA A26, B40, and DR9 can be seen. Then coming to the classification of keratoconus based on the shape of the cone. The first one is the nipple or small diameter, which is less than 5 mm. It is small round shape, inferior or inferonasal in location. The nipple cone is paracentral and is easiest to fit with contact lenses. Then oval or large diameter, which is more than 5 mm. It is inferior or inferotemporal steeper cornea. Oval cone is more difficult to fit with lenses, and the apex of the cone is displaced well below the midline, resulting in varying degrees of inferior mid-peripheral steepening. And the third one is the globus, or the largest diameter, which is more than 6 mm. 75% of the cone is affected, and overall steep cornea is there. Globus cone is the most difficult to fit with the lenses. Then patients in early stages are usually asymptomatic. There is progressive visual blurring or distortion of the vision. Photophobia, glare, diplopia can be seen. Asthenopia, ocular irritation is seen. Frequent change of glasses, as it is a progressive disease. Poor best corrected spectacle visual acuity. In acute hydrops, pain, photophobia, watering, and redness can be seen. Coming to the signs, external signs, the first one is the Munson's sign, where a V-shaped conformation of the lower lid lower lid is produced by the ectatic cornea in down gaze. Then Resurtius phenomenon, in which a light reflex projected from the temporal side is sharply focused and displaced beyond the nasal limits when high astigmatism and steep curvatures are present. Corneal thinning from half to 1/5 of the normal thickness at the apex of the protrusion. Histopathology shows stromal thinning with focal breaks in the Bowman's layer, shown by the black arrows. In Vogt striae, these are fine vertical lines in posterior stroma just anterior to the Descemet's membrane. These are parallel to the axis of cone and disappear transiently on digital pressure. Fleischer's ring, this is the earliest sign on the slit lamp examination, where a yellow-brown or olive-green pigmented line at epithelial level is seen. It is partially or completely encircles the base of the cone. Deposition and collection of the iron hemosiderin anterior to the Bowman's layer in the adjacent basal epithelium can be seen. It is best seen with broad slit beam and cobalt blue light. Cobalt blue light absorbs the it is absorbed by the iron line, delineating the conus and causing it to appear dark. In the image, you can see the landmark is indicating the location 1 as base of the cone, and second is the pupillary margin. Corneal scarring, reticular, subepithelial, and anterior stromal scars develop within the cone. Other signs are epithelial nebulae, subepithelial fibrillary lines. Then acute hydrops, there is rupture of Descemet's membrane. Stromal imbibition of aqueous causes corneal edema. Defect closes and the deep stromal scarring remains. So it can be managed by compression sutures with non-expansile gas mixture if the large cleft is seen on aesocity or it is a non-resolving hydrops. Retroillumination signs, scissoring reflex on the retinoscopy is the earliest clinical sign of keratoconus. Oil droplet sign or Charlotte's is cone. Cone appears as oil or honey droplet when a red reflex is observed. It is based on the total internal reflection by conical cornea. It produces a dark round shadow in corneal mid-periphery, separating the central bright red reflex from the red reflex in the corneal periphery. Then based on the Placido disc, early keratoconus focal area of increased corneal curvatures appear as an isolated area of small ring spacing and distortion. With progression, the ring spacing decreases overall and becomes increasingly irregular. Placido photokeratoscopy signs, compression of the Myers centrally or inferotemporally. These are egg-shaped Myers. Central rings show a teardrop configuration termed as keratokyphosis. Initially, keratometric signs, there is absence of parallelism and inclination of the Myers. As the disease advances, the Myers appear smaller. Then video keratography signs, It is based on the analysis of several thousand points, and the display of the corneal curvature is it forms a color-coded contour map on the corneal surface. The color coding is as follows. Red and orange indicates steep curvatures. Green and yellow indicates normal curvature, and blue indicates flat curvature. Instruments that measure the corneal surface can be divided into two general types. First one is the Placido disc based using a reflective Myers, and the second one is the elevation or depression recorders using either slit scanning apparatus, Schemflug rotatory camera as in Pentacam. These are the topographic patterns of keratoconus. First one is the round pattern. The second is the oval. The third, you can see there is superior steepening, then the inferior stiffening, irregular pattern, then symmetric bow tie with skewed radial axis, asymmetric bow tie with inferior steepening, asymmetric bow tie with superior steepening, asymmetric bow tie with skewed radial axis, and a symmetric bow tie. Videographic suspicious sign of keratoconus in axial map, the keratometry more than 48 diameters. There's localized increase of surface power, which is usually present in the inferior or inferior temporal cornea, approximately in 80% of the cases. Relative skewing of steepest radial axis above and below the horizontal meridian, SRAX pattern. Skewed radial axis more than 21 degrees. Inferior to superior dioptric ratio of more than 1.42 diopters, and there's against the rule astigmatism. Tangential map is more accurate than the axial map. Inferior steepening and the superior flattening are present in the patient with the inferior cone in the first image. And the second one is asymmetric bow tie pattern with skewed radial axis of astigmatism. Elevation map here, elevation map for elevation values of more than 12 microns on anterior elevation map in central 5 mm area, and elevation values of more than 15 microns on posterior elevation map can be seen. Pachymetry value, thinnest location of less than 470 microns, displacement of thinnest point of more than 500 microns from the center. Pachymetry asymmetry in two eyes at thinnest point more than 30 microns, and superior to inferior difference at 5 mm area of more than 30 microns can be seen. Coming to the Rabinowitz diagnostic criteria, it is a special keratoconus indices. Keratometry value of more than or equal to 47.2 diopters. Inferior versus superior corneal dioptric asymmetric value of more than 1.4 diopters, skewing of radial axis of more than 21 degrees, and SIMK value of astigmatism of more than 1.5 diopters. Then KISA percentage, it is based on 4 parameters. The first one is the K value of central corneal steepening. The inferior to superior value, it is the expression of the dioptric asymmetry. Then AST index, which quantifies the degree of regular corneal astigmatism, and the SRAX index, where the expression of the irregular astigmatism occurs in keratoconus. The KISA percentage of more than 60% suggests keratoconus suspects, and if it is more than 100%, strongly suggests keratoconus. Then coming to the modified Amsler-Krummeck classification, where stage 1 of keratoconus is characterized by eccentric corneal steepening, and induced myopia and or astigmatism is less than 5 diopters. Corneal radii are less than 48 diopters, and Vogt striae can be seen, and there is no scarring. Stage 2 is where induced myopia and or astigmatism is more than 5 diopters but less than 8 diopters. Corneal radii are less than 53 diopters, and no central scarring is seen. Corneal thickness is more than 400 micrometers. Stage 3 is where induced myopia and or astigmatism is more than 8 diopters but less than 10 diopters. Corneal radii are more than 53 diopters and there is no central scarring. Corneal thickness ranges between 200 to 400 micrometers. Stage 4 is where refraction is not measurable. Corneal radii are more than 55 diopters. There can be corneal scarring or perforation and corneal thickness is less than 200 micrometers. Then coming to the differential diagnosis, keratoconus, the similar conditions are pellucid marginal degeneration, keratoglobus, or posterior keratoconus. Here it shows the differentiation between all the four conditions. The frequency is most common in keratoconus and the other three are relatively less common conditions. Keratoconus and pellucid marginal degeneration, keratoglobus are usually bilateral conditions, but posterior keratoconus is usually unilateral. Age of onset is in keratoconus is puberty. It is 20 to 40 years in PMD and usually at birth in keratoglobus and posterior keratoconus. Thinning is seen in inferior paracentral area in keratoconus. Inferior band 1 to 2 mm wide is seen in PMD and it is greatest in periphery in keratoglobus and paracentral posterior excavation is seen in posterior keratoconus. Protrusion is thinnest at apex in keratoconus, superior to band of thinning in PMD, and it is generalized in keratoglobus and it is not seen in posterior keratoconus. Iron line, Fletcher's ring is seen in keratoconus, sometimes in PMD and posterior keratoglobus and not in posterior keratoconus and not in keratoglobus. Scarring is commonly seen in keratoconus and posterior keratoconus. It appears only after hydrops in PMD and it is mild in case of keratoglobus. Striae are commonly seen in keratoconus. It is sometimes seen in PMD and keratoglobus and not in posterior keratoconus. The topography shows AV pattern and SRAX pattern in keratoglobus. There is crab claw pattern in PMD and generalized steepening is seen in keratoglobus. Central steepened cone coinciding with posterior conus with paracentral flattening is seen in posterior keratoconus. In PMD, the maximal thinning is inferior to the area of maximal ectasia. This is best seen with a narrow slit beam. Corneal topography in pellucid has a butterfly pattern with steepening at 4 and 8 clock hours. In addition to far inferiorly, superiorly and inferocentrally, there is flattening. Form thrust keratoconus. This is a subclinical keratoconus, can be diagnosed only by video keratography. Usually it is asymmetrical. Central keratometry is more than 47 diopters, oblique astigmatism of more than 1.5 diopters, and superior to inferior curvature disparity of more than 1.4 diopters. Posterior keratoconus is not a true keratoconus. It is usually unilateral, non-progressive, non-inflammatory, associated with a normal visual acuity, associated with Peters anomaly. Altered Descemet's membrane and endothelium in the area of the defect can be seen. Myopic astigmatism can be corrected with spectacle to prevent amblyopia. Pseudokeratoconus, topographic patterns simulating keratoconus are seen. It is seen with hard and soft contact lens wear. It induces patterns of inferior steepening and disappears with time after contact lens wear is discontinued. Coming to the management part, spectacle correction is given in mild cases with spherical and regular astigmatism components. In moderate to severe cases, inferior decentration and steepness of the conical apex causes significant amount of irregular astigmatism. Higher order aberrations which spectacles cannot correct optically. Then rigid glass permeable contact lenses. Contact lenses improve vision by means of tear film fluid gap between the irregular corneal surface and the smooth regular inner surface of the lens, thereby creating the effect of a smoother cornea. Contact lenses must be tailored to the individual's visual need and comfort tolerance. In early stages, soft contact lenses can be advised, and in later stages, rigid gas permeable contact lenses are advised. The ideal fluorescein pattern is called the 3-point touch, where a bullseye pattern of concentric rings are seen. Lens bearing a shade between the apex and the mid peripheral cornea, and a central feather touch and peripheral edge lift of 0.5 to 0.7 mm is seen. Advantages as it is simple to fit and are well tolerated by the cornea, easy to insert, remove, and clean, and are relatively inexpensive. Disadvantages are limited success when the apex of the cornea is decentered, usually inferior. The lens will tend to center over the apex of the cornea, which can cause visual axis to be outside the optical zone of the lens. Then the piggyback lenses. Soft contact lens silicone hydrogel is placed beneath a RGP lens. Indications are when the RGP lenses causes discomfort or intolerance. Then unstable RGP on the eye popping out of the lens. 3 and 9 o'clock staining with RGP fit and a presence of scar. Advantages are that it improves vision and comfort. Disadvantages: lost RGP, giant papillary conjunctivitis, difficult in handling and maintaining two lenses, and a high risk of hypoxic changes can occur in the cornea. Scleral lenses. Boston scleral lens prosthesis or a fluid ventilated scleral lens. BSLP are made up of fluoro silicon acrylate polymer. Diameter is 15.5 to 20 mm. There is a vault over it vaults over the cornea and the limbus and is supported entirely by the sclera. Space in front of the cornea is filled with a non-preserved buffered saline solution. This fluid smoothens the irregularity of the cornea and provides good vision. Indications are when all other contact lenses fail to improve the vision, there is inability to get an optimal fit with RGP or intolerance. 3 and 9 o'clock staining of the cornea, vascularization with PBCL and advanced keratoconus, scarring in the cornea, corneal edema, and acute hydrops. Advantages: used even in severe cases of ectasia, work well in patients with concentric ocular surface disease, large diameter, excellent centration, clearer vision through the optic zone, additional comfort as lens sits on the insensitive sclera. This large diameter allows lens to have minimal detectable movement to the patient and minimal lid interaction. Disadvantages: lens have complicated fitting and the fitting appointments can be numerous and lengthy. If improperly fitted, corneal abrasion, corneal neovascularization, and conjunctival hypertrophy may occur. Contraindicated in patients with glaucoma, drainage devices, and endothelial compromise. Then the rose-K contact lenses. This is a unique keratoconus lens design. Optical zone is reduced to snugly fit the cornea. Complex computer-generated peripheral curves to fit the rest of the irregular cornea. And the system incorporates triple peripheral curve system where there is standard, flat, and steep to achieve the ideal edge lift of 0.8 mm. Then intracorneal ring segments or intacts. Insertion of intrastromal corneal ring segments. Two clear arcs are inserted of a variable thickness up to 450 microns. It is made up of PMMA material. The arc length is 150 degrees. Outer diameter is 8.1 mm and the inner one is 6.8 mm. It is implanted in the peripheral peripheral cornea at 7 mm optical zone to induce a change in the geometry and in the refractive power of the tissue. Intacs inserted at depth of 70% of the corneal pachymetry outside the 7 mm optical zone. When inserted peripherally, they induce focal steepening, causing stretch of the periphery and leading to central flattening. The amount of flattening is determined by the insert's thickness. Inserted mechanically or by femtosecond laser assisted techniques, it reduces astigmatism, regularize the anterior corneal surface and induce hyperopic shift. Then collagen cross-linking with riboflavin and UVA light. Riboflavin, vitamin B2, it possesses the function of absorbing UV radiation by triplet stage, and photosensitizer, it generates a reactive oxygen species leading to oxidation of procollagens. It releases free radicals forming chemical bonds within the molecules of extracellular matrix, such as collagen type 1 and proteoglycans, leading to cross-linking. This increases the mechanical stiffness of the cornea. By Dresden's protocol, the step 1 is removal of the epithelium by blade or alcohol, cotton swab. Then there is imbibition stage. In this stage, according to the corneal thickness, if the corneal thickness is more than 400 microns, isotonic solution is used. And if the corneal thickness is less than 400 microns, hypotonic solution is used. In isotonic CXL, 0.1% isotonic riboflavin and 20% dextran every 5 minutes with BSS in between is used. Hypotonic CXL, after initial application of isotonic riboflavin, hypotonic riboflavin without dextran is applied for 10 minutes until the thinnest point of the cornea becomes more than 400 microns. Contact lens assisted CXL is when it is more than 400 micron thickness of the cornea. It doesn't depend on the swelling of the cornea, and riboflavin soaked contact lenses are used. Checking of the saturation of the cornea by presence of riboflavin in the anterior chamber under blue light can be seen. Step 3 is when UV application is done, 370 nanometer, 3 milliwatts per centimeter square for 30 minutes over 8 mm diameter of central cornea is initiated after stromal saturation with riboflavin. Then accelerated CXL is where 30 milliwatts per centimeter square for 4 minutes is given. The advantage is just less time duration with a similar effectiveness is seen. Then epithelium of CXL is when it is done with removal of epithelium. It is easy, effective procedure, and post-op pain and decreased visual acuity can be seen. In epithelium on CXL, CXL is done without removing the epithelium. It is non-invasive. It is useful in uncooperative patients and in patients with dry eye and thin cornea. The image shows the strengthening because of the cross-linking. Indications for corneal transplant: when the contact lens failures are there or intolerance is there, central scarring precluding good vision with contact lens, and poor visual acuity despite tolerating the contact lenses. Deep lamellar anterior keratoplasty, the goal is to achieve a depth of dissection as close as possible to the Descemet's membrane. Risk of graft failure for DALK is twice than that for PKP. Visual outcome. Sir?
It's more than PKP.
Sir.
It is less.
In keratoconus.
Less with 30 years.
Okay. Visual outcomes are seen with DALK with PK, but are less predictable. Elimination of risk for endothelial rejection is less. And development of glaucoma may also be up to 40% or less. Coming to the complications, Uren-Chevalier syndrome causes fixed dilated pupil with iris atrophy, intraoperative DM perforation, pseudo-anterior chamber or double anterior chamber formation, interface keratitis by candida, and interface vascularization can be seen. Then penetrating keratoplasty, it is the surgery of choice for keratoconus as there is 93 to 96% success rate. It is currently reserved for advanced cases. 7.5 to 8.5 mm host refine is used. Cone is often displaced inferiorly and should be removed completely to avoid residual or recurrent disease. In severe conus, graft size may be more than 8.5 mm and there is increasing risk of graft host rejection. Recent advances, there is additive keratoplasty where insertion of a corneal lamellae obtained from a human donor cornea or from a lenticule extraction procedure within the ectatic area to restore the lost thickness and reduce the conic protrusion. Then Bowman's layer transplantation. It is a mini invasive technique that reinforces and flattens the cornea. And gene therapy where target gene sequence is modified by means of a viral vector which integrates into the cell DNA and provides translation of a healthy and functional protein.
Any other this thing, newer advances like Bowman membrane transplantation, which is
Bowman's layer transplantation.
let us see. Any other procedures for keratoconus treatment? One was DLK, but before that lamellar keratoplasty used to be done. So DLK is further. Okay, so in DLK there is a chance, small chance that it may perforate. So then you have to convert it to full penetrating keratoplasty. What is the role of intact at present?
It helps in flattening the cornea.
How much can it flatten?
Up to 3 diopters.
Yeah, so it's not like it doesn't change it huge, but main use of intacts is that it might improve the spectacle corrected vision for the patient. So suppose patient doesn't want to use the scleral contact lenses, then we can try intacts and improve the spectacle corrected vision. Okay. Yes. One more treatment you have missed is pachychial. Pachychial can be done, but it will correct only up to the spectacle corrected vision. So aberrations will stay. So that is very important to understand. And suppose patient has is using scleral contact lens, and patient wants, I don't want to use scleral contact lens. Let's do the pachychial. But if you do pachychial in that case, and if you use the toric pachychial, then when the patient starts using scleral contact lenses again, that cylinder will come with the refraction. Okay, so if in case the patient wants to use scleral contact lens afterwards also, then we can correct only the spherical. Okay, so the scleral contact lenses can be used. Only advantage will be that without scleral contact lens also patient may see little bit okay without glasses. Okay, another thing you missed was mini scleral contact lens. So what is the difference between scleral and mini scleral?
The diameter of the size of the lenses are smaller in mini. 15 to 17 mm.
Scleral is more than 15. Less than 15 will be mini scleral, usually 14 or less. Okay. So they will sit more or around the limbus. So that can also be used as compared to, of course, the comfort of scleral will be more than mini scleral. Away you go from cornea, comfort will be more. But scleral contact lenses are much bigger too. Then I think one more thing, another thing is topo-guided laser ablation with C3.
Combined procedure.
So that is also can be done. What the aim of that treatment is that you reduce the amount of aberrations while correcting with C3 also. So you reduce the aberration, then do C3 to fix the cornea. So the chances of spectacle corrected vision improves. later on. And also then the patient can go for a phakic to correct whatever is the residual error. So nowadays that is also commonly being done for, rather than doing only CPR. Okay, of course, not in all cases it is possible, but in many cases it can be done. And you have not talked about the how to detect the progression of keratoconus. What is the criteria?
Progression we have to see firstly if it is a woman, and in pubertal age or during pregnancy or menopausal, in any stage, if there is a change of even 0.5, then we have to treat that patient because of the hormonal changes. In case of male patients, if he is pubertal, then we have to treat because it usually stabilizes by 30. So during that stage, if there is change of again 0.5 diopters, we have to treat
0.5 diopter change in
asymmetry.
Change in asymmetry of 0.5.
Like the progression from the previous scan.
Or steepening of the cornea. So there are criteria which, and again another problem with these is that every machine has a pretest variability. So if you do say pentacam of the patient, same patient in the same sitting also 10 times, every time you will have a different. So the whatever the progression is, it should be beyond the retest variability. For example, say 0.5 diopter is the variability in the machine itself. Then it has to be more than that to say that it has actually progressed. And what is the after C3R, how long the effect lasts?
C3R effect, we usually see changes up to 1 month, but it is seen that the changes can occur up to 1 year also. So we don't treat the patient again with C3R with that one for next year. And if the progression is there beyond that, then after that we can do a repeat C3R.
But what is the usual effect of the C3R? Till what time? Suppose C3R is
6 months.
No. C3R effect usually lasts 3 to 5 years. So you don't have to repeat C3R generally for at least 3 to 5 years after the first C3R. We don't do it every 6 months also. I'm saying C3R. After C3R, the cornea stabilizes. Its effect lasts for 3 to 5 years. So generally, there is no progression in that period. But after that period is over, you may find again progression. So in that case, we may have to repeat C3R. It's very rare to require C3R before that, unless it was the ineffective C3R, like the riboflavin did reach properly. Okay. What is the difference between epithelial on and off?
We remove the epithelium.
And which one is better?
It depends on the corneal thickness. If the thickness is less, there's no need to remove the epithelium. The better will be removal so that the penetration is better.
Penetration of what?
Riboflavin and UV rays.
It requires oxygen for the interaction. So when you have epithelium on, the penetration of oxygen is less.
Yes.
Okay. So when there is epithelium on, then effect is not as significant as epithelium off. In fact, most often it is not considered as the effective C3R. Okay. So the same thing when you do smile with C3R. In smile with C3R, what they do? The pocket is created, and in that they inject C3 riboflavin, and then C3R is done. So again, the issue is that whether the enough oxygen is reaching the stroma or not. Okay, though studies have shown that it is also effective, but we are not exactly sure whether the effect is same as epithelium of C3R.
Okay. Which is a refractive procedure of choice, and smile is in case of keratoconus.
Best is to have trans PRK procedure. If it is a form for keratoconus and still patient wants refractive procedure, then PRK extra, what is it called? So PRK is done, and after that C3R to correct, to make sure that there is no progression. So So most of these procedures have shown good this thing long-term safety profile in terms that there is not much of progression, but then it cannot be guaranteed because it's already a weak cornea. So there will be a small chance that it may progress.
So there is also some role of cyclosporin that is
Immunomodulators for
reducing the inflammation.
yeah. So mainly we have to major risk factors which can be controlled is the allergy and the rubbing, eye rubbing, which is mechanical rubbing. So that has to be controlled in children. Mainly those are the individuals who have high risk of developing keratoconus. So that has to be controlled. And another thing is cleaning has to be done properly. So if any child comes with astigmatism, it is better that you do the pentacam done. So you know that this patient may have higher risk of developing keratoconus. Like thinner cornea is there, deepening is there, or there is slight asymmetry which is detectable. So then you have to follow up these children more frequently. Okay, because in younger than 16, the progression is seen very fast in the keratoconus. So generally, so most of the guidelines suggest for wait for the progression, clinical or history of progression of the keratoconus. But in pediatric age group, it is better not to wait and go ahead with it because they invariably progress and progress very fast. They may go into hydrops or very significant thickness. So it's better to treat them with C3M. Okay, any questions?